We know large cell lymphoma is the most common lymphoma, about 1/3 of the cases. We know that about 50%, over 50% of patients can be cured with R-CHOP type chemotherapy, about 20-30% of relapse, and 10-15% can be primary failures. The real challenge is that these failures are very poorly. They occur 80% of the cases, 80% of these relapse occur in the first 18 months. And they're usually a very challenge for salvage, even with hydrotherapy and transplant. So therefore, this is very important to try to have markers that help us identify and prognosticate and stratify patients. So I would say there's three types of factors, and there's the lymphoma factors that we know there's large cell lymphoma is a very heterogeneous entity. Primary cell large cell lymphoma, for example, is a separate subtype. But under the NOS subtype of large cell lymphoma, there's different molecular subtypes. The cell of origin, GC, non-GC, and classifiable. But well beyond that, now we know that TXC7 is very important, MYC, BCL2, double expressor, double hit lymphoma. And beyond the FISH, typically the definition is by FISH, but there's about 50% of these high-grade double hit lymphoma that have a very poor prognostic with standard R-CHOP, that have the signature of a high-grade lymphoma but do not have the FISH by gene expression profiling. P53 next-gen sequencing is not done yet in routine, but this is trying to narrow down the molecular subtype. And then there's the tumor burden of the lymphoma, the stage, the LDH, bulky, and the baseline metabolic volume if you want to go by PET scan. The second aspect that was developed is a prognostic model, trying to put this in context. And we have the IPI in the 90s, we had the revised IPI in the R-chemo era, and we have the NCCN IPI that is trying to use the same factors basically as the basic factors of the IPI, but it's trying to stratify better the age and the LDH, and try to identify better smaller subset, particularly on the extreme, the very good risk and the very high risk patients. There's something that is interesting called the EFS24, and then that means that in the patient who have no failure after 2 years, so therefore the EFS24 name, and these patients do very well, similar to the population, control population that never had lymphoma. And in order to identify these factors, there's the IPI24, there's a calculator available online that also use similar factors, but it adds actually gender, bulky, and lymphocyte count at baseline. And there's another factor also that is to take into account the diagnostic or delay to start treatment versus immediate treatment, which obviously the patient would start within 2 weeks versus more than versus later usually have more symptomatic and worse outcome. And that's really important because these factors that are clinical factors essentially based on the to characterize each patient have been very helpful, but not really to predict the long-term outcome, but not to predict the response to therapy. So there's some host factors that are important. We heard about gender, comorbidities, we'll talk more in a minute, but there's a number of factors that are not yet used in the practice. The class 2 MHC expression, the beta-2 microglobulin, which is a class 1 component of a class 1 molecule, microenvironment signature, inflammation, cytokine, vitamin D level, etc. So this list obviously is growing, and those are more the host factor. And this prognostic, again, predict for the EFS, PFS, and survival, but not for the early failures, which is our real problem that I mentioned before. And finally, the response to therapy is the PET scan, and the PET scan, interim PET scan, although is debated, when it's a negative PET scan, regardless of the stage, even in advanced stage, this is usually a very good outcome. Sometimes it is in non-specific inflammation and residual gray zone like PET scan with low SUV. And what matters is the delta of the drop of the SUV. But typically in routine, what we really look at is the patient who have a negative PET scan at the end of treatment. That's what's very predictive. And here, I would just like to mention that when someone has a residual PET scan that is positive or doubtful, I mean, I think it's important to biopsy this patient because we need to know if it's a truly active disease because it has some huge consequence. And then finally, I think there's something that is another factor that is emerging, and I think that will take more role in the future on prognostic factor, the circulating tumor DNA or cell-free DNA. that is detectable in all patients at baseline, regardless of the stage, reflects the tumor genetic makeup or signature profile, if you want. And studies, not large studies, but very impressive. Patients who are PET negative and cell-free DNA negative after 3 cycles do remarkably well. So this is a number of factors, and I think this is, how do we use this in practice? So in a frontline setting, R-CHOP has remained the default, but it's not sufficient for high-risk patient, double hit and double expressor and non-GC lymphoma. But it's important to understand that we can start to adjust with the treatment. So in a non-GC subtype, so far the attempt to do better on R-CHOP have not really panned out. This is about 1/3 of these non-GC are double expressor, and we know that they do very poorly with R-CHOP, so we try to give them something more intensive. And finally, the high-grade lymphoma that I mentioned, these guys do very poorly with R-CHOP, and definitely there's no standard therapy. We tend to use, if you're a younger patient, a Berkey type, a McGrath regimen, or EPOCH in elderly patient. And that's the impact of in a nutshell, of these prognostic factors in lymphoma.
So the question is, what is the prognostic and predictive significance of the DLBCL genetic signature? So the recent stratification of DLBCL has evolved over the years, while next generation sequencing have shown valuable information. There is an absence of a specific drug or medication that will target these specific gene signatures. So its application in routine clinical practice remains elusive, in my opinion. So, however, it underscores the fact that there is a need of developing trials using these genetic risk stratifications. One of the challenges I see using these tools, like a next-gen sequencing or gene expression profile, is the cost, the availability, and especially reproducibility. That it will be difficult for physicians who are not familiar with this testing to make the interpretations.